Our next speaker is Nick Carney, who jumps out of helicopters for fun. He's a critical care paramedic for New South Wales Ambulance, and he's come to talk to us about the work that he does out here regionally. If you could welcome Nick, please.
Thank you. Hi guys, as you can see, my name's Nick Carney. That is a photo of me there. I can guarantee it's not a selfie. It was taken by the doctor in flight, and the camera was quite safe and wasn't about to fall out of the aircraft. Very humbled to be asked to come and present to such a wide cohort of my peers. Certainly didn't really know what I was going to be able to bring to you guys, and certainly thought any number of my colleagues would be better suited to present to you guys. But here I am, and certainly thankful for this opportunity. My current position is a critical care paramedic at Orange. I've been there for 3 years now. Prior to that, I worked last 10 years out of Western Sydney for New South Wales Ambulance in various roles. P1, worked my way up to extended care paramedic, intensive care paramedic, and then obviously I've progressed on to critical care paramedic. During that time in Western Sydney, I certainly took for granted the large number of resources, ambulance, police, fire, that are at my beck and call, essentially. How close I am to any hospital, and particularly the major trauma hospital being Westmead for that in my area. Worst case scenario, I'd be 60 minutes drive, and that's sort of in a stark contrast to what we experience out here in Western Sydney, in Western New South Wales. So 3 years ago, accepted the transfer to Orange, and then I've quickly learnt the challenges that we face in Western New South Wales. My career progression. As you can see, I started out as an RN before joining the ambulance service. During one of my clinical placements as a student, a first-year student, I was in ICU, and during that time, a retrieval team came in to take over care from a patient and move them, and they left a lasting impression on me. Just the way they carried themselves, communicated with all the other staff, and also managed to treat the patient, and I was blown away of what they were doing in terms of titrating inotropes, adjusted ventilator settings, and from that moment I sort of knew that was the direction that I wanted to head. So as you can see there. So New South Wales Ambulance Aeromedical Retrieval, our model is a doctor critical care paramedic model. We have two platforms that we generally operate from, first one being the helicopter, obviously. Part of our team is the air crewman and the pilot. The air crewman, for me, is a really good resource and certainly probably undervalued. Essentially, their role is strictly aviation, navigation, landing the aircraft on the ground. But for us on the ground as a paramedic, we can delegate them to set up the cabin. We can say, oh, we've got a tall patient or expecting to have a CT6 or a Slishman to splint the femur, and straight away they know how to set the cabin up. They can set up ventilators. So once I've got a packaged patient, I can turn up to an aircraft and I know it's good to go. Just pop them in and it's done. These guys aren't medically trained, but they're more than welcome to jump in, get their hands dirty and take direction from us. Part of our platform is road retrieval at Orange. Most of our work is done by helicopter. We will jump in the road retrieval car for primaries, sort of a close-in area, anywhere from the 20-minute area around the base, and we'll respond by road. Any sort of outside that platform, then it's getting into the area where a helicopter will be quicker in consideration for start-up, landing, and then also fuel considerations. A big part of Aeromed is RLTC and also ACC. These guys are behind the scenes. I think local ambos will certainly know. Rapid Launch Trauma Coordinator, pestering them for a mist. You guys turn up on scene, you've got a lot going on, and RLTC want a mist to know whether or not to task us. So these guys, RLTC, are responsible for tasking aeromedical teams for primaries, and then once they've tasked us, they'll send us to Western Control, but they'll still provide overwatch and clinical support for us if we need. ACC, so Aeromedical Control Centre, they've sort of got the overarching look on what's going on across the state. They're looking at intensive care beds, movement of patients from secondaries, so which is called a secondary, which is moving from a small outlying regional hospital into a major one. And they've sort of got that global view of what's going on. Also part of Aeromed is New South Wales Air Ambulance, RFDS, and also NETS. There's a designated NETS aircraft based out of Bankstown, which is set up, ready to go, and will respond and move a NETS team across the state where it needs to be. That NETS aircraft just happens to be the busiest in terms of flight hours in comparison to all other helicopter assets across the state. So the medical team, what can we bring to a job? So we've got a vast number of skills, medications, and networking, as you can see there. So RSI, we carry 3 units of O-negative blood. We've got 2 ventilators, an oxylog and a Medumat. Both function in different ways. Our Medumat is used for our primary. It's quite sort of a simple ventilator. Our oxylog is used for more complex ventilating strategies. We carry ultrasound. Thoracostomies is quite a common procedure, which is in the event that a patient tensions, they'll cut a hole inside the patient's chest. It's quite agricultural in the approach that they scrape the muscle off the chest wall and then place the finger into the pleural cavity and then pierce through that to relieve the pressure. Clamshell thoracotomy, there's only been 1 or 2 that I know of in the Orange or Western area. In Sydney, they've done a few, and there's only been 1 survivor. So essentially, it's cutting the patient in half, opening up the chest and exposing the pericardium to see if we can relieve a tamponade and then get the heart beating again. So that job presents multitude of logistics to consider. Certainly, in our setting, it would be quite difficult to get prolonged care for that patient and then get them to a general surgeon who's willing to take on that presentation. So in terms of secondaries, we've got CPAP, BiPAP, so looking after your COPD, asthma extremis, those sorts of things. Vasopressors for your septic patient. Emergency hysterotomy. There's only been 1 done by our state, our New South Wales ambulance. So essentially it's a pregnant woman who's gone into cardiac arrest, and we need to get that fetus out ASAP. So there's certain guidelines, 32 weeks gestation, and also the timings that we need to get that out. So unfortunately, it is making the incision, get the baby out, and then you've got 2 patients to resuscitate. So thankfully, I haven't done that, and hopefully I'll go my career without ever doing that job. Lucas 2 is coming to our road retrieval cars. It's probably not looking likely it'll be on the aircraft platform anytime soon. Lots of ongoing testing to go for that yet. Okay, so lots of complex things going on there. So yeah, lots of skills, lots of medications, but essentially none of that matters if the basics aren't done. And this is sort of my interpretation of pre-hospital care, and it's all about the basics. Getting the right patient to the right hospital in the right time. The first crew on scene set the tone for the job. They wear the brunt of the job, they're confronted with bystanders, they're seeing firsthand the damage at an MVA, the house fire, the burns, and basically from them, they set the tone for the job and then give us the opportunity as a medical team to value add, not to take over, but to add. A quote that I was sort of quite fond of and came across, it was on TACMed Instagram page, so I've stolen it from them. But as you can see there, sort of has 2 meanings to me, in that getting the first dressing, getting it right the first time, and that also reiterates the importance of that first crew on scene and how much they have to contend with and how important their role is. The AW139 helicopter, so it's a twin-engine aircraft. It's all-weather capable. Having said that, it can fly in snow, but one of the limiting factors, particularly for us out at Orange, is the freezing level. So as the weather cools down, the freezing level comes down with that. And then we're obviously at altitude at Orange, so we have a decreased flight buffer, and it gets to the point where we can't actually take off the ground, and that's when we're going to be offline and not able to fly and help you guys. Dual patient capacity, so it can take 2 patients. Worst case scenario, we'll take 1 critical patient who can be ventilated, and then also a second patient. During that method, it's incredibly time-consuming, lots of logistics in terms of packaging both patients, deciding who's going to be loaded first, who's going to be loaded second, where the doctor and paramedic are going to sit, where you want your equipment. It greatly impacts and limits the space that we've got in the aircraft. Nets platform, as I said earlier, set up at Bankstown. They're set up for also dual stretcher load for nets retrievals. Basically, they'll strip it out and then use all their own equipment. We have a bariatric capacity. The weights escape me at the moment, but sort of the loading platform is the great limiting factor in our aircraft. Once you factor in the weight of the stretcher, the weight of our monitoring equipment, and then also the PLD, which is the loading platform that lifts the stretcher into the aircraft. So I think, top of my head, weights of sort of 180 kilos, given that doesn't cover the entire spectrum of the bariatric patients that we see. The fuel range of the helicopter is 780 kilometres. Things that we need to consider in Western New South Wales is where we're going to get fuel. There's only a handful of sites that we can actually gas up and then be able to return to base. And we've got maps on base with all those charted, whether it's a fuel tanker, whether the crewman has to go old school and actually pump it out of a drum, or if there's actually no fuel available. And so this all comes into planning considerations before we accept tasking on a job. Maximum cruise speed, 300 kilometres an hour ground speed. So they're fast, they're big. They pump out about 6 tonnes of downwash. Imagine a vast number of you guys in this room have seen the damage and the force that can be done by the aircraft. Unfortunately, they've just about levelled a caravan park on approach to a scene. They've knocked over old ladies. The machine is quite powerful, and you need to be quite careful around it. So this is some of the data that's been collected since Toll took over operations at Orange Helicopter Base. It is missing about 6 months of data. The blue highlighted area in the middle there is Orange, and these numbers indicate landings at these scenes. So we're currently sort of pictured 113 is Dubbo, where we're located there. So you can see the spread of logistics of where the bulk of the jobs are, and you can also see how far we have travelled, virtually across the state to treat trauma patients. Part of the other data that they're actually collecting is they've sort of pinpointed all the jobs and then put all that in an algorithm and pinpointed where the base should be. And to date, since 2017, encompassing all those jobs, it looks like it needs ideal placement would be Molong, which is half hour north of Orange. But when you consider Orange is our regional trauma centre, then Orange is certainly the most appropriate destination for Western New South Wales. Just play this video in the background. So video certainly depicts the dust that we in Western New South Wales are going to contest with, and also 6 tonnes of downwash, what it can do to a scene. So just going to let this video play for a little bit, but during this time, the pilot very quickly loses visual reference, as you can see with the dust sort of building up in front of him. So his eyes, his ears essentially become the crewman, and then to a lesser extent the paramedic. So we're constantly scanning out, looking out for hazards, making sure there's been no debris that's been blown up as a result of the downwash, and just waiting for it to lower. So in this scenario, the pilots actually engaged auto hover, and the helicopter will just sit there perfectly still in a hover, and then sitting there, blow the dust away, and then gradually we're just trimming down the height, and then coming down, and once it's at a safe level, get the aircraft on the ground, and we can jump out and start making our way to scene. So challenges there that we encompass in Western New South Wales: isolation, limited resources, the longer response and transport times, the absence of a major trauma centre. We do have regional trauma centres, Orange, Tamworth, and staging trauma centres here in Dubbo, Griffith and Armidale. This is the other perspective of that scene. We'll just point out this paramedic, clearly it's not his first rodeo. He knew what he was in for when he was landing the aircraft on that scene. Full PPE on and running to get out of the way. So my perspective is that there's lots of small cogs in a big wheel. Aeromed and a medical team is also a very small cog in the big wheel. And all those cogs work together to implement the New South Wales trauma plan. And at the heart of that is the T1 protocol and early activation through RLTC. So case presentation that I was directly involved in, I think a couple of other people in this room were also directly involved in. So this was north of Rylstone, east of where we currently sit at the moment, 35-minute flight time to scene. Just give you guys a second to flick through the MIS report. So on our way to the job, we had notes that the deceased motorcyclist was actually in cardiac arrest. So a relatively short flight time. During that time, myself and the doctor are sort of engaging in conversation, figuring out what our plan is going to be once we get on the ground, knowing that we've got two patients, one's almost deceased but still being worked on, so he's got to be our priority. So we need to focus our resources on that second patient, that first patient, and then divert to the second. But on our way there, before we got overhead scene, that first motorcyclist was pronounced deceased, so it made our decision quite clear-cut and easy that once on scene, we were going to be directed to that second patient. I think it's worth considering at this point, it was one ambulance that was on scene, so two paramedics, and they were faced with that. So they've got two patients, they've performed resuscitation attempts on a deceased motorcyclist. There's friends, there's family, bystanders all on scene, adding to the pressure, and then there's radio comms, RLTC, and probably myself pestering them for misreports, and they've got all this to consider. So for me, it shows what paramedics in Western New South Wales deal with and deal with very well. Just mention the collar there as well. So this patient had a bull neck and wasn't suitable for a rigid collar, so we've just implemented manual immobilisation. So on arrival, so we are on scene about 8 minutes after the initial paramedic team. So on arrival, patient's lying on the road on his right-hand side. Approach the scene, you can certainly get a rapid assessment of airway. You get an idea of perfusion status just by looking at how pale he was diaphoretic, he looked anxious and distressed. So straight away that sort of gets me triggered and thinking, okay, this patient's sick. We're going to be working quite quickly and hard here. So airway, patent, maintaining his own, manual line stabilisation as said before, and then moving on to breathing. So increased respiratory rate, talking in sentences, but still quite anxious. His SATs were high in the 80s and increasing surgical subcut emphysema on the left side of his chest as well. Decreased breath sounds on that left. Circulation, as you can see there. So long bone injuries that we saw on scene was gross deformity to his left knee. At the time, I thought it was tib-fib fracture and then wasn't going to implement a CT6 at that time. So neurology, GCS 15, moving all limbs independently except for the left leg, which at that time we put that down to increased pain because of the obvious fracture and deformity that he had there. Past history of the patient, he had cervical and also thoracic surgery with fixation to both. What next? So maximal concurrent activity is what we want to happen and it's sort of the ethos of Aeromed. So we want all hands on deck trying to get maximum interventions done as timely and as efficient as possible. So priorities, this patient's tensioning, so we need to decompress the left side of the chest. Luckily for us on that day, we had an intensive care paramedic on scene, one that I've worked with before and one that I'm quite happily to delegate to perform that procedure, knowing that it's going to get done, it's going to be done well and efficiently. We can't treat a patient that's lying in the middle of the road, so we need to get them up, off onto a stretcher, in the shade. We need a T-pod, we need to look after their pain, we need to splint the leg, we need second IV access, and judging by the trajectory of this patient, I need to break away to perform an RSI kit dump, and also need to consider blood and ultrasound. So as we're rolling this patient, he's with some ketamine on board. Basically, he's declared himself. He decompensated quite significantly, dropped his sats, heart rate's gone up, blood pressure was difficult to palpate but remained the same, and then positioned in the supine position, relocated to the back of the ambulance where I've left the local paramedic crews to load that patient, and I've broken away to perform my RSI kit dump. Just go back there. So with the decompression, there was a huge relief from the patient. Straight away, he could like, I can breathe. So it was instantaneous, and it was a really good demonstration of how well the pneumofix works. RSI kit dump. So there's a few things that we want to look for. So obviously we've got our checklist there. Is 360 degrees access around the patient. I'm sure there's quite a number of you guys that have experienced RSIs with us in the past, and we've all got similar with just subtle differences in our approach, but ideally we're going to go to the back of the ambulance. We've got oxygen, we've got suction, we've got your equipment rather than using ours. One thing that I sort of look for is, in terms of the sun, is point the ambulance directly at the sun. We're going to be working at the back of the ambulance, so straight away that puts us into the shade. RSI preparation, so each of us have our own little significant way of setting up that field, but I won't sort of go into the details of that too much now. Airway brief is a big one that we all do. I find the big benefit for me is going through the drills, and my airway brief is always the same, that I go in deep with laryngoscopy. The video's kicked off to the side to the doctor. I'm looking for the epiglottis to fall into view. If I can't get that, I'm coming back slow. If I still can't get a view, I'll grab the doctor's hand with ELM, position it, looking for a view. If that doesn't work, I come out, change of operator. And then from there, we move on to change of operator. Doctor, if he can't get a view, we move to an iGel. If we're unable to ventilate with an iGel, we're moving to a surgical airway. I'm hyperflexing the neck. I'm bringing the patient up off the bed, and the doctor will choose which side of the bed they're going to cut from. Every RSI we go through that, so that freshens that approach in our mind. And also, if we get into trouble, we've already said it out loud, and we hope that one of the paramedics, potentially someone in this room, will go, "Hey Nick, you said you were going to move on to this now," and then it's just that little prompt for us to move on before we sort of start circling the drain with the patient. So this patient had a pretty poor blood pressure and effectively had a low flow state. So initial dose was 70 milligrams of ketamine, 150 milligrams of rock, and then we've given that at induction. We've waited our 60 seconds. Patient's gone apneic. We're happy to progress to laryngoscopy. I've attempted intubation. I've gone in for laryngoscopy, and then the patient had a gag reflex. So rather than proceed and attempt, so if we proceed at that point, potentially we're going to increase pain to the patient, we're going to spike intracranial pressure and lead to complications from there. So the best approach is to pull out, keep ventilating the patient, keep the sats at 100%, and then go again. So we waited 2 minutes this time, should be more than enough. There was a flush to make sure that the line was still patent, another dose of 50 milligrams of rock and 70 of ketamine before the next attempt. And the same thing, patient moved his mouth. It took the third attempt before we actually were successful with the intubation, and then confirmed with end-tidal CO2, and then from there we're able to progress on to the next step. I will explain the low flow state and why the medications weren't as effective a little bit later on once we see the patient's injuries. So treatment, we've secured the airway. The doctor's going to move quite rapidly to decompressing the left side of the chest. It's much more definitive than the Russell pneumofix, and as I said earlier, it is quite agricultural in its approach and aggressive. So thoracostomy is performed, and then straight away he was able to tell that the lung was down, but a huge amount of blood came out onto the stretcher, onto the floor, requiring an intercostal drain to be inserted. Drainage bag then, 1 litre of blood straight away. So from there, we've got a huge amount of blood on the floor that we can see, and we're going to start activating some blood and also start looking at ways to implement pre-hospital retrieval transfusion protocol. So it was previously known as MTP, but recently it's changed to retrieval transfusion protocol. SAT's not improving, right finger. So SATs were poor, so we troubleshooted that, make sure it wasn't left or right, worked it on the ear, looking for different sites just to confirm that our SATs are true for what we've got. Enrolled the patient in patch. Calcium is an essential medication that we need to give. Basically, the way that packed red blood cells are stored and treated with citrate depletes the calcium from them. And if calcium is integral in the clotting cascade, so we need to boost and replace the stores that are left, that have been lost for that patient. Pre-hospital retrieval protocol. So this scene was isolated. We had no radio comms. We had no mobile phone reception. I've tasked the DOM to leave the scene, gain some communication, and then activate RTP for this patient. So consideration, there's sort of a decision point that needed to be made. So where we were 45 minutes to Westmead being the major trauma centre, or do we divert 15 minutes to Bathurst, pick up more blood products, and then travel 35 minutes onto Westmead? So quickly we need to decide, is this patient going to last 45 minutes to Westmead? And I think everyone agreed on scene, no, we're going to divert to Bathurst, get some more blood products, and then continue on. So in packaging the patient, we lost our 2 IV access. This line security is a big thing for us in Aeromed. It is our lifeline and the patient's lifeline. If we lose those, it puts us straight behind the 8 ball again. And these patients are quite shut down and can be incredibly difficult to get IV access again. So retrieval transfusion protocol, ideally it's activated by phone call only to ACC. There's been a few incidents where communication to Western or directly to pathology and it's dropped the ball and led to delays. This time that wasn't the case, and retrieval transfusion protocol was activated in a timely manner and the system worked. So we carry packed red blood cells. Essentially that's just volume, replacing what the patient has lost. It's not replacing the clotting factors that are actually going to help the patient create a clot. So FFP, cryo, platelets, that's the stuff that the patient needs. On this instance, the patient only got, it's sort of a lucky dip when we activate MTP, RTP. We get a box, we don't know what's in it, we open it up. 9 times out of 10, it's just packed red blood cells. We don't get those clotting factors that the patient needs a lot of. So activating RTP, MTP, so sort of the poster that ACC has put out is sort of a quick representation of the information that they want. They're going to be jotting this down on a form and then sending that direct to pathology. In the background, they're speaking to us and they're determining where we're going to go, and then from there they can determine whether we fly direct and get the blood or the blood comes to us via police, ambulance, or any other available resources that are there. So for us, this side of the ranges, heading towards Sydney, Bathurst, Lithgow, Orange, we can stop in, grab some blood, and continue on to a major trauma centre. Bleeding control. So a mnemonic that I sort of go to all the time in identifying bleeding sources, places. So pelvis, long bones, abdominal, chest, external extremities, and skull. Going through those, you're pretty sure that you're going to find a bleeding source amongst those. Short, sharp, and it's easy to remember. Trauma triad of death. There's a lot to that. I'm a big fan of this concept, but there's sort of very little that we can sort of value add. And leading into winter, I want to talk a little bit more about hypothermia and the detrimental effects to our patients. So in our environment, it's very easy to, we need to expose a patient, find out where the injuries are, and straight away they're going to be cooling off very quickly. It's very hard for us to actually warm those patients up, so we need to be mindful of that and limit temperature loss as much as we can. In Aeromed, we have access to a sleeping bag and also a chemically activated warmer, so we can wrap the patient up inside the sleeping bag and keep them warm. It keeps them a little bit too warm sometimes, but it is effective in warming a patient up. So coagulation, not the best graph, but this is sort of all that I was able to find. So a little bit of representation on terms of body temperature, and then also the delays in clotting factors. So the bottom one was APTT time, and the top one is prothrombin time. I guess the main point of that is to show the subtle changes in temperature and their effects on coagulation. And I guess the ethos is cold trauma patients die. Another one of the stats that I came across was that with a temperature of 32 degrees, 100% of those trauma patients will die. So ongoing care, we stopped at Bathurst. There was a delay there. We were sitting on the pad nervously waiting the arrival of the blood products. Our crewmen's jumped out and sitting there waiting at the lift, waiting. Blood products arrive, we jump in, we take off. We've got 4 packed red blood cells. We didn't, in this instant, get clotting factors. So patients kept warm, they're enrolled in patch trial, calcium's given. Cefazolin, so broad spectrum IV antibiotics, while it's not sort of one of the sexiest things that we do in Aeromed, it does have great outcomes. It's long-term down the track, decreases infection, and then as a result decreases hospital times. En route, this patient was pretty saggy, so we were working pretty hard. We churned through all those blood products quite quickly, and fortunately the patient made it to Westmead in a relatively good state. Code Crimson was activated to Westmead, and then they were there ready, waiting for us on arrival. Received by the trauma team, and he was off to OT within 15 minutes. One thing that I sort of learnt in sort of getting ready for this presentation was Code Crimson. It meant a different thing to me that I activated Code Crimson. We went direct to theatres, but when I sort of looked into it, I was able to find the algorithm as recommended by New South Wales Health, and basically it comes down to the point that we arrive in ED, hand over patient to the ED team, and there's a whole host of people that are activated, and then so they do a quick primary survey on the patient, and between the ED consultant, the surgical consultant, the trauma consultant, they make a decision, a disposition on where that patient will head, whether that's OT, CT, or interventional radiology. So 24-hour follow-up on this patient. As you can see, quite a significant C1 fracture with displacement. T8 fracture. It actually turned out that he had a femur fracture and a left subclavian artery dissection. So this dissection actually explained sort of decreased blood flow to that arm, was going to lead to decreased venous return, and then hence the slowed effect of our medications that were given. So we had the blood pressure cuff on this arm. Obviously, we're not going to give our induction meds through that. We're going to pump them through that. So unfortunately, that's why we had the slowed result. And then, rib fractures, pneumothoraces. Laparotomy was negative. 24-hour follow-up showed that he was moving all limbs when sedation was weaned. You can see the thoracic fracture there. Unfortunately, I don't have further follow-up on this patient. So effectively, all of us are small cogs in the big wheel for trauma. So the P1, resuscitation attempts on that first patient, got the mist out, oxygenated the patient, got IV access. Level 5 provided decompression with the pneumofix. The medical teams come on board. We've value added where we can. We've contacted ED. They've put out the trauma call, activated OT to sort out the patient's injury to his subclavian artery. He's gone to interventional radiology, ICU, and there's a whole host of other things that are sort of happening in the background to get all this sort of activated and up and running. Further to that, there's some more small cogs in the big wheel, all listed there. Sort of running out of time, so I'm not going to check through that one. Debrief. At the completion of every job, we run through a debrief led by the pilot. Essentially, it starts out as an aviation debrief, highlighting any risk factors or adverse events that came because of that, and then we'll move on to a medical debrief. This patient had a non-compressible hemorrhage. We activated MTP, we activated code crimson. We had permissive hypertension in flight, so being sure that we didn't raise the patient's blood pressure too high that we're going to pop clots. For me, secure IV access. Since then, I've sort of learnt a lot, and I've actually found a great video for securing IV access. Wasn't able to embed it on the PowerPoint, unfortunately, but for you guys, if you go to YouTube, GSA HEMS, they've actually got a procedure using a combined bandage to secure a line. And it's so secure, in fact, that the IV line will break before the cannula is dislodged. So I'd certainly recommend that you guys look for that one, and it'd be great if we could start to see that in the field. Communication, always a big one to debrief, and hazards of landing on a road. Thank you.